Hello everyone. Thank you for joining us today for the latest edition of our Alberta SPORE Knowledge Translation webinar series. I hope everyone can hear me. Please indicate, maybe one or two people could indicate yes through the chat if the sound is okay. Yes, thank you very much. My name is Cheryl Johnson. I am the Training and Professional Development Program Coordinator for the Alberta SPORE Knowledge Translation Platform. I am delighted to welcome you today to the session entitled Researcher-Practitioner Collaboration to Translate Knowledge into Practice. We have two presenters today, Dr. Lisa Guirguis from the University of Alberta and Dr. Shao from the Alberta College of Pharmacists. Lisa Guirguis is an associate professor in the Faculty of Pharmacy and Pharmaceutical Sciences and is also the director of graduate studies for the faculty. She conducts pharmacy practice research that influences health policy and supports patients' and pharmacists' roles in patient-centered care. As you'll hear today, her knowledge translation tools focus on practical strategies to help pharmacists engage patients in dialogue about safe medication use, and these tools have been adopted by provincial and national pharmacy organizations. Dr. Shao is the Professional Practice Director with the Alberta College of Pharmacists and is also an instructor in the Orofacial Pain Clinic at the Faculty of Medicine and Dentistry at the University of Alberta. In her role with the Alberta College of Pharmacists, Shao is responsible for developing, implementing, and maintaining methodologies and strategies to measure, monitor, support, and improve pharmacist and pharmacy technician practice in pharmacy practice settings. Before we begin, I'd like to let you know that this session is recorded and the link will be provided along with the presentation slides to all participants after the webinar. The format for today's webinar will be a 35 to 40-minute presentation followed by time for questions. You can send your questions anytime throughout the presentation by using the chat screen. And Lisa and Shao will take these questions at the end, but feel free to send your questions anytime and we'll keep track of them. You'll also see a link to the ACP, Alberta College of Pharmacists website on the screen, just above the resources section in the bottom right-hand corner. All the knowledge translation tools you'll hear about today can be downloaded from this site, and we have some links in the resources section as well. I hope you enjoyed today's session. On behalf of the Knowledge Translation Platform, I welcome Dr. Shao and Dr. Lisa Guirguis, and will now hand the microphone over to them.
Thank you very much, Cheryl. This is Lisa Guirguis here, and I'm going to start today's presentation. And I'm really honored to be here and thrilled to talk about the work that Shao and I have started. We reflected back, and it was about 2010 when we, 2009 when we initiated this project, with our first workshop in 2010, and the project has been growing since. So we'd like to tell you a little bit of the backstory. What was it that brought Shao and I together to work on a knowledge translation for a pharmacist strategy? How have we been working together over the years? And what are some of the products that we have made to help translate knowledge into practice? Shao and I are fairly practical people, and we're going to show you some tools that are actually being used in practice currently today. So if you see on the side, Chat, Check, and Chart is our logo. This logo actually just started 2 years ago. The Chat, Check, and Chart name has been around since 2009, and just for the record, neither Shao or I thought about it. We had a very talented individual at the Alberta College of Pharmacists who did communications, and I'll talk about how she came up with the name for us. Today, what I'd like to do is talk about our knowledge translation, but I wanted to put it in terms of the CAHR knowledge action to knowledge cycle. I'll be honest, Shao and I, when we first got started, did not go and find a model and look how we were going to do knowledge translation, but as we've moved forward and looked at evaluating this, we've been really reflecting on how what we've done suits this, where we are and where we want to go with knowledge translation and evaluation in pharmacy practice. So what we like to think of is when we look at knowledge creation, we did not look at knowledge inquiry or knowledge synthesis. A lot of the knowledge that we needed about practice has already been brought together in documents such as the Standards for Pharmacy Practice and research that's available from Albertan researchers and researchers around North America. What was needed was a way to get this knowledge into practice in the average frontline community pharmacist. So when we talk about knowledge creation, we were solely focused on the tools and products. And what we wanted to do is, we start off, I'm going to talk about how we identified our problem and figured out what knowledge we needed to do. So I love this picture. It's actually two pharmacy students who are now have been pharmacists for a couple years. I like this because your pharmacist has you covered with how they were going to promote pharmacy practice. Pharmacies, they may not look it, but they're very unique in North America. Pharmacists in Alberta have the broadest scope of practice. Your community pharmacist who's in any pharmacy in Alberta can access your electronic health record. That's a list of all the medications you get at any community pharmacy. They can also look at your lab values, no matter who ordered them, so your lab results, as well as some information on hospital discharges. So they can get information on your health. Pharmacists in Alberta have been able to inject since 2007, so they provide flu shots as well as many other vaccines and other injectable medications. Pharmacists prescribe in Alberta, and there's two real forms of prescribing that the way most people feel about it. Number one, pharmacists can continue your prescription, but if pharmacists prove their competence, they can also assess you and provide an initial prescription. Our pharmacists in Alberta can order lab tests, and we're one of the few provinces that has this right now. We have regulated technicians, so while a pharmacist has to assess if a prescription is the right one for you clinically, a regulated tech can make sure it's the right pills in the bottle. And that's been a big move for practice, and I'm going to come back to that in a little bit. And finally, there's been a reimbursement model to support pharmacists in providing this care. So this started in 2007 with some of these other additions coming later. So practice in Alberta has exploded. It's almost a tsunami of change. We've had more change since 2007 than we probably had in the last 30 years of pharmacy practice. And along with that, we have to have our practitioners change. The Alberta College has done a lot of neat ways to try and empower pharmacists. And just one of the ways they looked at improving patient-pharmacist care was to engage patients in the care. And they actually had a series of radio ads and newspaper ads promoting the role of pharmacists. And this is just one such example. It says, your pharmacist, a key player on your healthcare team. And then it tells a little story about how Tim couldn't play his soccer games because of his asthma. And the pharmacist, assessed him and helped and prescribed an inhaler refill for him so he could get back in the game. And, it was a neat way to engage people and promote the practice of pharmacy. I put this slide up. It's a picture of a pill mill. I'm not suggesting that all pharmacies are Lego pill mills, but a lot of people, when they think about pharmacists, they don't think of that long list I had with the umbrella picture. They more think of a place where you go to pick up your prescriptions, and you see those people in the back who are busy doing things with computers and bottles and vials. And this is a lot of what people see and expect from pharmacy practice. And my favorite is the dosage. Instead of age, they have dosage on the side of this, 5 to 30 milligrams. I take no credit for this picture. It was on the net and shared. But I'll just leave it here. So I'd say some of the expectations are a little bit low for practice, and there's some unclarity about pharmacists' role. Of course, like all other professions, we have standards for practice. And as a pharmacy educator, the story really starts with me looking at, it was actually a prior version of the standards, so these parts are the same. I was looking at the standards for practice and educating a group of pharmacy students. And we were talking about the fact that the guidelines require a dialogue between a pharmacist and a patient for every new prescription, every time you buy a product behind the counter that doesn't need a prescription, or any time the pharmacist suspects a drug-related problem. And then the student said to me, well, that means we don't need to talk to people at refills. And I said, no, it means exactly the opposite. How can you know if a person's having a drug-related problem if you haven't talked to them unless you're omniscient? So we went back and forth for a bit, and then I realized there was some unclarity. So that's when I contacted Shao, and we had a discussion on the interpretation of the guidelines. And we realized that, yes, the guidelines really do support pharmacists speaking at refill and talking to patients to solve these problems. However, we noted, and it's widely known, that pharmacists may not be engaging in all of these conversations. Shao and I have been trained, she has a PharmD, I have a PhD, and we've been trained in looking at how patient care is delivered. And between the two of us, we knew of practice tools that could definitely help pharmacists out in moving towards meeting these standards. So what I'm going to do next is show you some of these tools that we took and then adapted to local knowledge in the Albertan context. So this is our tool card. It's called the Chat, Check, and Chart tool card. It describes the initial tools that Shao and I knew have been successful in other locations to help pharmacists raise the bar for practice. And we wanted to find a way to introduce them to pharmacists in a non-threatening manner. So we started off with chatting to our patients. So if you're going to talk to them, don't just start a conversation in general. Have a focused conversation about 3 topics called the 3 prime questions. What's the purpose, direction, and monitoring for therapy? These are used widely in the U.S. It came from the Indian Health Services down there. These questions were focused. So you could talk to patients with good and poor health literacy and talk to them and assess their information needs and provide information. The second tool was the check, which is the pharmacotherapy workup. This is a thought process that pharmacists have to assess therapy. And then we look at charting, how we document that care. These are all based in a pharmacy practice model called pharmaceutical care or the patient care model. But these tools are shortcuts, we have noticed, or short or quick ways these have been operationalized for pharmacists. None of these 3 chat, check, and chart tools are unique to Alberta. What we have done is bring them together in one package to show pharmacists how they could deliver enhanced care over the pharmacy counter. Part of the reason we did this is right now a lot of the time a pharmacist will ask a patient or a technician will ask, do you have any questions for the pharmacist? And the patient will say, no, I'm good. And we actually believe that patients should not be solely responsible for when you should talk to a pharmacist. The pharmacist needs to engage the patient to ensure medications are safely used. So that's the philosophy underlying this. So this slide looks a little bit busy, but I'm going to talk you through it. And what we've got here is under the title dispensing, we can consider this current practice or was current practice. It's definitely been moved since then in Alberta at the time we started the model. And the patient focus could be our chat, check, and chart model that we've been using. So when we look at chatting, we have assessing for accuracy profile and check the medication history. We know that this is being done fairly accurately in pharmacies. The idea of talking with your patient to find out what the medication indication is, what the patient either understands the directions to be, or if this is a refill, how the patient is actually taking the medication, and monitoring for drug therapy. So is it working? What problems are you having? So these are the chat tool, and we can see that in dispensing, this may or may not be happening. It may be happening ad hoc when the patient requests it. Some places it happens all the time, and other pharmacies it doesn't. And that's one thing that the chat model requires. When we look for checking for prescriptions, we know that pharmacists are stellar at checking for the safety of medication. It's their main focus when they're looking there. However, pharmacists, if they're not asking the chat questions, may not have sufficient information to check for indication, effectiveness, and is the patient able to manage that. And that's more in the check part. And what we've changed, instead of checking for safety, we call it appropriateness, checking for appropriateness. And finally, charting. Pharmacists have incredibly accurate files on the medications that patients are taking. When they load them up to the electronic health record, they are fairly accurate. They're probably one of the best sources of drug information. However, pharmacists are not always documenting the patient care or the conversations they're having, and that's when the chart part of chat, check, and chart. So this tool really talks about how we took the local knowledge of what's happening, looked at where we wanted to be, and what tools we'd use to get there. So the next stage is to assess the barriers to knowledge use. And And what we did, and we've had 2 publications on this, the first thing we did is in 2010 we created a workshop on the chat, check, and chart tools to introduce them to pharmacists. This was an interactive workshop. It had limited presentations, many cases, and many problem-solving sessions. And being researchers, we evaluated the role beliefs and self-efficacy. What was their competence? And then did they believe that pharmacists should be checking and charting prescriptions? And I can tell you that we had a fairly significant lift. It was statistically significant, but also meaningfully different scores on the survey instruments after our workshop. We were able to really convince pharmacists using this model that they could and should be providing this level of care. The next step was to look and see how they used it in practice and what kind of barriers they met. That's the second paper here in the Journal of the American Pharmaceutical Association, and I'm going to talk you through some of this findings. So this is a mixed method, qualitative, quantitative study that followed up on a group of pharmacists that were in the workshops. So first of all, we asked them, have you been chatting and checking once you got into the pharmacy? And what pharmacists told us is they told us they were at a variety of levels. And we wanted to see what did it look like. And we had some very honest pharmacists. Honestly, the package is waiting for me to open it up. And I don't know about you, but I've been to many a workshop where the binder sits on the side. And that's what they told us. And we actually hadn't developed the tool card at this point yet. We had a binder. And it was this idea that there was a package they had to open seemed to be a barrier to this. Some people had awareness. Some people felt we could do it in quiet places but not busy. Those who were implementing it said things like, I like to do the drop-off because I can ask questions. So they were talking about when and where they were using these tools. And there were some pharmacists who'd already implemented that. Now, documentation we looked at separately because documenting care was rarely happening in community pharmacy. And again, we had some 2 very honest pharmacists who tell us it was excellent, but we didn't implement a single thing, right? And then we had people who are thinking about it, they're trying it out, and people who have made a real change. If there wasn't anything outstanding, I didn't really document it. Now I will. So this is a subset of people. They obviously are probably the more engaged people who continued with our follow-up. We followed up with about half of the participants in the original workshop. However, we did see a variance. The reason we split independent and chain pharmacies is sometimes, not always, in independent pharmacies, the pharmacists have more ability to influence practice themselves over how the software is used in things, and they may be able to find workarounds. And we see some evidence that perhaps that was happening. More importantly, though, we asked them, what are the barriers? What is preventing you from doing this? And the first thing they said was patience. Well, the patients actually coming to my pharmacy, they're all pretty much interested in how fast they can get the medication and the price. So if my patients don't want this, I'm not going to provide it. Patients were sometimes listed as a facilitator, and this is someone talking about how they counsel patients at refill. Things change, and the circumstances, certainly what they went in for could be something totally unrelated. And if you don't have this consistent line of inquiry, you're going to miss that. So you talk to them the first time they took the medication, but is it still efficacious 2 years later? Pharmacists were quite honest. Some of them admitted freely, you know what, I'm the barrier. I'm the one who's stopping this. Other pharmacists talked about, this was a manager talking about her pharmacist. Pharmacist's duty today is just to do the 3 CCs, and she will work just like any other healthcare professional. And when pharmacists saw this as the job of pharmacists, not producing an accurate product, but a clinically safe and assessed product, when that attitude was present, it was definitely a facilitator to change. The pharmacy itself, of course, provides barriers. I find the other pharmacists I work with, they're just here to fill and bill. And I know this is confidential, so I can say that, but it does really frustrate me. And other pharmacists who had tried that said the improved workflow was a positive benefit because they were talking with patients up front about some of these barriers with the chatting, and it stopped them having to fix and fill prescriptions twice because they found errors on the back end, and an improved workflow, which is better for pharmacists and patients alike. So when we went through this process, we clearly found barriers to what was happening here. So what I'd like to do is take this to the next level, is how we tailored our tools in order to meet some of these barriers and really move our model to something that could be scaled up wider for practice. And I'm going to hand this over to Shao.
Thanks so much, Lisa. So when I first arrived at the college, I was responsible for a couple practice consultants. And the way their roles had evolved was that they were originally known as inspectors, and they still are under the legislation. And then they were called practice or patient safety advisors, and then finally they were called practice consultants. However, their role wasn't necessarily reflective of that. And we quickly realized that in order to ensure that pharmacists are meeting the standards or exceeding our standards, we can't expect change overnight. It really does reflect the necessity of moving pharmacists through a stage of change. And we based a lot of our tools and our methodologies around Prochaska's stage of change or trans-theoretical model. And we quickly realized that we had an opportunity here to use our practice consultants to go out to the pharmacies and not just inspect and not just assess the operations, but also influence practice and influence positive practice change. And so we decided to focus on academic detailing on our standards as well as chat, check, and chart. So based off of the original chat, check, chart tool, we designed several tools that looked at how you talk about chatting, how do you check up on checking, and how you actually plot the chart, and how you actually document. And these were to supplement our original tool because it wasn't simply just asking the question and saying, well, tell me more about your medication. And some patients would say, well, don't you know about my medication? You're the pharmacist. So it was about how do you articulate that in a way that respects the patient's opportunity to make decisions with their care while also respecting the pharmacist's expertise. We also realized that every pharmacy is at a different stage of change, and so we really had to tailor our academic detailing to that. Also, different pharmacies in different geographical areas had different challenges as well. One of the common challenges with our scope of practice originally was that pharmacists were able to have prescribing authorization, and also that included adapting prescriptions. So providing prescriptions where perhaps patients had forgotten their medications, the pharmacist would then do an assessment, ensure that the medication was still effective, safe, and indicated, and the patient was still compliant with that. However, pharmacists weren't exactly sure how they could do that. What did checking mean? Because it wasn't necessarily now making sure that the right pill was in the right bottle. So we came up with a tool on chat, check, and chart for adapting a prescription. And you can find all of these tools on our ACP website. This was found to be very helpful. We have revamped the tool, and we constantly do review our tools to make sure that they are relevant as practice changes. The other tool that we created was assessing an opioid prescription. We do have significant issues here with respect to opioid abuse and also opioid diversion. And often pharmacists aren't exactly sure what to do with a prescription, especially when they notice issues and they call the doctor and the doctor says, well, I want you to dispense it the way I've written it, and I support this, this medication that I've just prescribed. So what does a pharmacist do when they see that prescription? What sorts of questions should they be considering? And so we identified some very specific chat questions for reviewing an opioid prescription. as well as things that they should be checking for. For example, would a non-opioid be more appropriate? Would there be an opportunity for some non-pharmacological interactions? Is this even the appropriate opioid? And would a long-acting formulation perhaps be more appropriate? So those are just some of the questions that pharmacists have learned to ask with this tool. The other realization that came about after maybe 2 or 3 years into this process was that we needed to really talk about the success people were having with Chat, Check, and Chart. So it wasn't just enough to say, hey, here are some tools that you can use to help facilitate your assessment and your documentation, but what are the successes that other pharmacists are experiencing? And so we created a new tool that talked about that. What kinds of new information are pharmacists learning? And one interesting realization was that when asked about their medications, 1 in 7 patients actually described an indication that was different from what the pharmacist had expected. And so this was new information that had the pharmacist not gone through the Chat, Check, Chart process, they would have never uncovered. And we have numerous anecdotes about that. The same thing occurred with chatting about refill medications as well. So 1 in 4 patients actually were using their medications in a different way than the pharmacist expected. So this was a great opportunity to really check in with the patient and find out how is that medication going and what kinds of interventions can pharmacists do at refill. It is not simply just filling it again and having the patient go their way. Finally, something that revolutionized our discussion about Chat, Check, and Chart, a little bit difficult to say.
The first year was
the first year was the worst, yeah. We identified some vital behaviors. So what are vital behaviors? They are behaviors that take about 20% effort, but give you 80% impact, or 80% of your result. We wanted to really pinpoint what are some specific things or activities that pharmacists can do to help facilitate patient assessment and to help facilitate patient care. So the first one was connecting with patients. You do need to engage patients at every encounter and talk to them and find out what their needs are. One important point that we are bringing to pharmacists is the importance of identifying who you are and what your role is and what you're there to do. This helps to set patient expectations, and it actually opens up the dialogue. We also ask that pharmacists confirm and document indication. How do you know what you're assessing if you don't know what the medication is actually for? And so that has been going very well, and we've had significant uptake with this. The other vital behavior is accessing NetCare. We are very fortunate to have the electronic health record available at our fingertips. And this supports our standard of gathering appropriate information to do a patient assessment. And so we have been encouraging access of NetCare to review lab values to ensure that lab tests that should be done are being done, and to review any imaging or other medical reports and to understand what the final results are in order to continue that dialogue with the patient. And finally, we've just modified this last behavior. We are now calling it patient monitoring, but what we really mean is assessing at refill and ensuring that pharmacists are reviewing prior documentation and also continuing to evaluate medication therapy according to CHECK. So are the goals of therapy still being met, and have there been any new side effects or are there any compliance issues? And then documenting that so that any pharmacist can follow up. So the next item that I want to go through is just how are we monitoring knowledge and use of these tools. And my background is actually in marketing and sales, and so we know that multiple interventions actually can help to create sustained practice change. And so some of our strategies include trying to minimize practice change failure, identifying and promoting vital behaviors to sustain change, assessing according to the RIC model. So RIC is a registered trademark of Health Change Associates. And RIC talks about readiness, which is in your very busy day as a pharmacist, are you ready to implement some of these vital behaviors? Can you implement them? It also looks at importance. Do pharmacists know why they should be implementing these vital behaviors? Do they know how it might affect patient outcomes? Do they have the confidence to do this? Do they feel prepared to do this? Do they have the systems and tools in place to do this? And knowledge, as you'll notice, is a small k because it actually plays a very small role. We know the pharmacists have the knowledge, and do they have enough of that to ensure that they can implement a lot of these different practice changes? Our consultants also do a lot of motivational interviewing, really trying to understand the pharmacist's motivation in light of all the things they need to do every day. And then they identify sources of influence. And these sources of influence originated through an organization called Vital Smarts. And I will definitely talk about that in the next couple of slides. But we try to influence by employing at least 4 out of 6 influences. And we're really trying to transition from product to practice, really trying to move from the transactional to patient-centered care. Our focus as consultants is on quality improvement, and we are moving towards assessing team-based performance. How can the team then influence individual competence? So I have 5 pharmacy practice consultants working across Alberta. Originally, we would see a pharmacy once every 3 years. However, now at our routine assessment, we are moving towards a 2 to 3 year cycle, and each visit is actually a set of 3 visits. So it includes the original routine plus a 6-week consultation and a 12-week follow-up to help to provide the support and also to assist with sustained practice change. We do an evaluation post-routine, and then we do another evaluation post-12-week follow-up. We've actually had really great success. We have had pharmacists come up to us and tell us that they'd like to see us more. You know, can we come out? They've suggested that more frequent visits would be really helpful. Our pharmacies are segmented as low, medium, or high performing, and so we do our visits accordingly. We try to engage our high performers to assist us with our lower performers. We also do a few more visits with our low performers, understanding that there may be other social and cultural issues at play here, or operational issues that need to be addressed before we can actually implement practice change. We really do believe that good operational systems support good practice. And we use a pharmacy practice index for assessment, and this includes demographics, practice environments, we assess staffing levels, we look at specifically assessment, care plan, and follow-up for very different processes, such as doing an injection or an adaptation or doing a comprehensive annual care plan. And then we review the documentation and their quality assurance programs, and we also review past complaints history. Our methodologies for assessment are actually rooted in chart-simulated recall. So that is, in addition to doing something like a chart audit, we interview the clinician to really get some insight into their thought process. This methodology is validated on the Kirkpatrick criteria, level 3, and so we're really looking at, are you able to implement these practice behaviors in your everyday practice? Are you able to make it routine or habitual? And Lisa and I will later on talk about what we're doing next, which is trying to look at level 4, the results. What kind of surrogate outcomes can we look at? What kind of patient outcomes can we look at? How are we influencing this? We use other methodologies in addition to this. I mentioned motivational interviewing, and we also use our influencing skills. So what is the pharmacist's personal motivation and ability like? Do they want to make the undesirable desirable? Do they have the tools and knowledge to do this from a personal perspective? What are others doing in pharmacy? Can we harness peer pressure? Are others starting to document indication or access net care? Do they have the support from their licensee to practice according to our standards? And do they have support tools from others? The last type of influencing or source of influence that we want to use is structural motivation, because it really refers to the rewards and punishment side of things. So that's the last source of influence that we would use, but is there a reward for this? Are patients happier with their outcomes? Are they coming back to the pharmacy? Is there a potential that they may need to have practice reviewed if they're not able to meet standards? We also look at structural ability. Do they have the systems in place, the technology, or the workflow to support practice? Our consultants also train on emotional intelligence. We try to focus on really building relationships and rapport with pharmacists and pharmacy technicians. And once we open that door, then it helps us to do our academic detailing on standards, and people are more open to listening to chat, check, and chart detailing on other initiatives that we may have. And then we provide the ongoing coaching as well. So we'll bring it back to Lisa to wrap this up.
Thank you, Shao. I'm going to talk about outcomes and knowledge, and I'm just going to speak to this slide right here. And I want to start by saying we cannot underestimate what Shao has accomplished here with the college. This is the first college of pharmacy in Canada that is actually looking at the practice of pharmacy rather than just looking at the structural supports. In a joking way, we used to say you have to make sure you have all your spatulas ready before the inspectors come and you have the updated references. And that has really changed in the last, well, 5 years, 6 years, into now I have to see how I'm talking with patients, and now I have to see am I documenting care. This is a radical shift. We are the first province to move this way, and I know there's been keen interest from at least 2 other provinces who have started moving this way and are thinking about how can they start evaluating practice, not just the structure. So I just want to give Shao a bit of a thumbs up there, because I think she really understated her accomplishment there. We have done some evaluation, not near enough evaluation of this, and that's part of what we wanted to talk about. Some of this success, we rolled out the product before we did a RCT on the effectiveness of it. You can say why or why not. Something was needed, and we needed to address, we had a need to address care and to implement the standards, and I don't think we were going to wait for an RCT on that. That being said, we have done some things to evaluate outcomes. Early on, we had a grant from Alberta Innovates where we looked at implementation within a small chain in a small group of stores, and that really provided us a lot of learning that informed the tools, such as charting the course forward or chatting. Like, we found out how we have to introduce chatting such that the pharmacists understand what we want is not a set of mechanical questions, but in starting to engage in a dialogue. Right now, actually, as of tomorrow, there'll be a survey in the field, in pharmacists, in a random sample of pharmacists in Alberta, looking at their asthma and how well they're managing asthma with patients, but also asking their awareness of the chat, check, and chart, and also how they're using it and how it has influenced their practice. Shao has noted with the practice consultants that at least 70% of pharmacists, if you hold up the tool card, will know what it is, recognize it. If you walk into a lot of pharmacies, it's taped up near the computer because it's one of those key skills they need. We distributed all new pharmacies in Alberta when they open, receive a package with the chat, check, and chart tools in order to explain to them how we see practice in Alberta in an accessible way. I like to think we summarize a large outcomes document into a tool card, and that's quite a success. The next step we're looking at in this is trying to reach the next level in Kirkpatrick, which is evaluating the impact on patient outcomes. And as any researcher knows, measuring patient outcomes can be quite daunting. And what we've been looking at is how to use pharmacy practice records to see the quality of care. For example, we can look into a certain disease area and say, in hypertension, are patients picking their prescriptions up regularly? And how persistent are they? And what percentage of patients are persistent within a pharmacy? And the idea being that we could use that to then randomly assign pharmacists areas to more detailed intervention in one area, such as asthma or hypertension, and not another area, and then look to see if there's a lift in these quantitative quality indicators that come from their electronic records. This is probably the next step and where we're looking at. The other thing I think that's really neat when we think about the idea of sustained, and I really praise the college for this, is they've held the course now for 6 years using one practice model. I don't know about you, but practice models come and go pretty quickly in pharmacy and in other areas. And the fact that we have one model that we have been using to adapt to different areas has allowed pharmacists to understand the core features of practice. When you check a prescription to adapt a prescription, it's the same as when you check a refill. The process is the same. There's just a few tweaks. And I think that sustained knowledge use is making a difference in practice, because we're not always recreating the wheel and reinventing something new. We don't have to start from scratch. Shao, is there anything else on the evaluation front?
Well, we are evaluating process outcomes.
Yes.
And we're very excited to get some data on that, and we're actually very excited to move to therapeutic indicators, as we've discussed before. And so looking at not just the process, but how our pharmacist is performing. For example, if you are a patient and you walk into different pharmacies, you should be able to receive very similar care according to the process, and you should actually end up with a very similar outcome as well. So how do we minimize that clinical variance? So that's where we're moving.
Yeah. Excellent. I would like to open the floor up for questions. We've left 15 minutes. We hope we've given you a broad overview of about 6 years and the different kind of tools we brought out and how we've done this. The relationship Shao and I have is wonderful. We work very well together. We are open. No one owns anything. And that's been probably one of the most important underlying principles in making this successful, is that ownership isn't an option. It's about how we move this forward in teaching and in practice simultaneously. So Cheryl, do you have some questions for us?
Yes, thank you, Lisa and Shao, for a very clear and very compelling presentation. First one is from Diane Oban. As one way of assessing patient impact, have you thought about asking patients to assess the effectiveness or usefulness of chat, check, and chart? So asking patients to comment on it.
Now, interestingly, Cheryl, you and I can comment on that a little bit. We have done some work in looking at communication with patients and how they perceive patient communication. And we generally find that patients are happy with whatever they have from pharmacists. So we have done work where we showed them different levels of practice and asked for their preference on them as well. It wasn't specifically just chat, check, and chart, but it was related to the question asking portion. And at first, patients, yes, we have done some, we have had some feedback, but definitely not enough. And I think a lot of it is we ask patients if they're happy, and they generally tell us, yes, my pharmacist asked me if I have any questions, and I love that. And I think patients don't realize what they can expect for pharmacists. And generally, when we show them, they're thrilled, and they ask us how to find a pharmacy that does this.
Yeah. And at our end, we are looking at patient engagement, and how do we do that within the pharmacy? And how do we actually directly ask them about the experience that they just had with their pharmacist and integrate the patient voice? So that's something that we're starting to look at.
Yeah, thanks. That's a great reminder for us. Thank you.
Thank you. It looks like there's a couple other questions coming, but I'm going to take advantage of the typing time to sneak one in. Knowing a little bit about the work Lisa and Shao have done over the years, can you just speak to what you see as the benefits of a researcher, an academic researcher and practitioner working together in this way, and then any challenges that might present as well, that particular type of collaboration?
This is Lisa. The advantage as an academic, I have no budget to make beautiful tools. Shao has access to fabulous communications experts who help polish our tools and refine them. Even the term chat, check, and chart came from a communications expert, and I would think that is something that's wonderful, and I've really appreciated over time. And I use these tools with my students, so that's wonderful.
And one of the many advantages in working with the researcher is there are questions that we want to ask, there are things that we want to measure, and to be able to tap into that expertise at a moment's notice has been very advantageous, and Lisa is just a pleasure to work with.
Oh, thanks. We can have a love fest. It has been very successful. I think part of it is I want to do Shao's job, and Shao wants to do my job. I would love to be working more with practitioners, and Shao said I'd be loving to do more with research. So we kind of see ourselves getting the best of both in this, and so neither of us has to switch jobs. We just have to hold tight.
Are there other questions from the floor? I saw some typing. Oh, thank you. Have you worked on other issues which made this initiative successful? Looking back, what have you learned, and what would you have and wish you had made differently? Would you like me to reread that? I kind of stumbled through the first
No,
time.
I'm thinking. This is Lisa here. I think I would like to have done more intensive research along the way with some of the tools to make sure we're really meeting pharmacists' needs. While we get feedback through the PPCs and Shao gets feedback that way, as a researcher, I would like to actually see the data myself. Mm-hmm. And Shao we share some, but I don't look through the records of the PPCs because those are confidential about the pharmacists. So how to get in and dig in a little deeper to what exactly is resonating with pharmacists with this. Just so you know, the lift in asking about indication is enormous. I wish I had baseline data on percentage of pharmacists asking about indication before and now, because I think it's changed in Alberta and it's too late to measure that.
And I'm really interested in moving our initiative forward to link it to other data that may be available through organizations such as Alberta Health, because this information is collected through Netcare. And mm-hmm. So are there ways to collaborate with respect to that to really make our initiatives and strategies more robust and more targeted?
Okay, thank you both. I'll do one last call for questions from the floor, and then we'll have that dead air for a moment while we wait and see if anybody else would like to respond. Okay, well, seeing nothing, I would like to close now, although you do have email addresses for both Lisa and Shao, and you can also contact them through us at the SPORE platform. So I would like to again thank Dr. Lisa Guirguis and Dr. Shao Li for the thought-provoking presentation, and thank you to our participants as well for joining us today. For anyone who joined us late, I will mention again this session has been recorded, and the link to view will be emailed to all participants who registered for the webinar. We will also include information about upcoming KT platform webinars and provide a sign-up link for our Alberta SPORE Knowledge Translation Platform newsletter to keep you up to date on coming events. Our next webinar will be on March 9th and will feature Dr. Denise Harrison presenting on Practice to Research to Practice, using diverse KT methods to improve pain treatment during painful procedures for infants and children. On behalf of the Alberta SPORE Knowledge Translation Platform, I'd like to wish everyone